I finished my residency in anesthesiology in New York City in 1982. I was board certified in anesthesiology, and subsequent to that, I became board certified in pain management, so I have double board certification. In 1990, I took over the Department of Anesthesia at Bergen Pines County Hospital, which is one of the largest hospitals in the United States at the time. And around 2000, I went into private practice, and I've been practicing pain medicine since that time. In addition to that, I've developed some products which have become licensed to the pharmaceutical industry. I was instrumental in patenting and developing nasal spray ketamine, and I have a number of other products which are now in the pharmaceutical pathway as well. Hi Bob, how are you today?
I'm good, thanks. How are you?
Good, good. So I'm going to talk about my approach to chronic disease, and my approach that, as you know, is to treat most, if not all, chronic diseases that walk in here as if they have a chronic infection until proven otherwise.
Okay.
We find that the source of those infections are in patients' mouths, almost invariably. In fact, 80% of the patients that we send out for dental evaluation have operable disease in their mouth. Of that 80%, a third to a half have dramatic improvement in their symptoms even without my treatments, which I'll talk about in a minute. So once we screen for that and we get that underway, then we treat the patients with a oxidative therapy. So you were saying to yourself, what is an oxidative therapy? There are 3 oxidative therapies. We use all 3 in this practice: hydrogen peroxide, ultraviolet blood irradiation, and ozone. All 3 have the ability to kill wide spectrum of microbial invaders, pathogens. The best of the 3 is ultraviolet, but we use the others as well. And the way we give the ultraviolet, since you asked, is we take out some blood from the patient. We keep it from clotting using heparin. We push it through a special ultraviolet light, enriching that blood and stimulating those red blood cells with the ultraviolet light so that they can actually glow. Now you can't see them glowing, but they're glowing, just like your watch dial. When you take off your watch and you put it in the drawer, it's still glowing from the sun. Well, that ultraviolet light that we use will get the red blood cells to emit ultraviolet light, and then when it's returned to your circulation, the ultraviolet energy will go throughout your body, killing pathogens everywhere. We sometimes enrich the blood with ozone as well. We'll put that into the same blood. And this is much safer than giving ozone any other way, because if you give ozone directly in a vein, you burn the vein up. We have people who come here who have veins burned from intravenous ozone. It's much more controllable, and it doesn't cost the patient any additional money to give it through the IV with the blood that's getting the UV. And what we see is a dramatic change in symptoms. And what we may not know is that if you come in with a problem and I don't know what it is, and I challenge you with an anti-infective dose of oxidative therapy, you will, and you have an effect on you, then we know you have an infection. We may not know what it is, but it's an infection. As I said earlier, I think most of it comes from the mouth, but many times people don't want to go to the dentist. They just want to be treated in the office. So we do use this therapy quite a bit. Did you have any questions about it?
Can you tell me the efficacy of how long it lasts? How often do you have to do it?
Okay.
Like even in my case, can you tell me about myself and what you found out about me?
Well, in your case, as commonly, you came in with multiple chronic problems, and you were sent for dental screening early on in the treatment course. Although you did respond to a combined technique of all three oxidative therapies. By the way, you were getting peroxide in a bath at home, just to round out the therapies. And intravenously, you were getting UV blood as well as ozone. But early on, you were sent for dental eval, and you yourself knew that you had a problem somewhere. You know, often the patients have an idea that they have a problem. They don't associate it with systemic disease, just like the doctors that we deal with don't connect the body either. So sure enough, as soon as the offensive root canals were removed, you had a dramatic change in your mental status. Everybody around here recognized it. The doctors abroad that had treated you recognized it. And although the oxidative therapies were able to keep a lid on it, it was only when we could get it surgically removed did you really get the full benefit. And that's the way it is with everybody. The oxidative therapies are a strong anti-infective therapy, and in some patients who don't have fixed infections, they'll get dramatically better. But patients who have serious fixed infections, as you had, they have to surgically have them removed before you see complete improvement.
If it's okay with you, I'd like to see a treatment done so that it's a very scary process. And I was going to say to you, when I first saw it and I saw a whole bunch of blood coming down from a bottle, I was going to say maybe you can walk us through so that you can take the fear out of it and explain what you're doing.
Okay, sure. Well, the first thing we do is get you comfortable and talk to you about what to do if you feel faint. Because many patients feel faint when they get anything stuck in them or even look at blood. So we go through a little drill to make sure that the patients will know how to recognize fainting and alert me, and they'll follow instructions when that happens. So putting this little safety precaution in place, we've had no patients ever injured from fainting. Once that's done, then we'll put an intravenous in, and we will then inject a small dose of heparin to thin your blood so that as it's coming out, it doesn't clot. Then we will take that blood and connect it to a curvette, which is an intravenous with glass tubing specially designed to go into the window of an ultraviolet light. All this is done with special glass, special light, and special timing. So your blood will come out, go through the light, and then be collected in a vacuum bottle. That we will take, in average patient, anywhere from 100 to 300 cc's of blood, depending on the patient's size and how much they've had in the past. Obviously, if somebody has had a good experience, we can push it up to sometimes close to 300. The sicker the patient, the less we want to take initially. We've seen patients who've had 10 or 20 cc little treatments, and they've had a response. So we see a response all the way from 20 to 50 cc's, all the way up to 300 cc's. Once we take out the amount of blood, passing it through the light, we collect it in a collection bottle. Now that collection bottle then gets turned over, opened up, vented, and sent back into the patient, again through the light. If we intend to give the patient ozone with the UV, we will put the ozone right into that bottle, right then and there. Swirl it around, and then the patient will get both ozonated blood and UV blood that has gone through the light 2 times.
Why is it so important to get oxygen into the cells? Does it help rejuvenate it or something like that?
Well, you know, oxygen in the cells is a good thing, but that's not what this treatment's all about. This is oxidative, not to be confused with oxygen. We do use oxygen to make ozone. Oxygen is O2. We take that O2 and we put it through an electrical field, and it cracks it into O3. So but it's in no way are we giving you respiratory oxygen. That's hyperbaric oxygen. It's a good treatment, but it's nowhere as near effective as oxidative therapy. The oxidative therapies, all of them, penetrate the cells and disrupt the DNA and RNA of pathogens. The human cells can tolerate this in the dosages we're using. The pathogens cannot. So we are treating intracellular infections with these therapies.
The reason why I was asking that question, I had heard about, they said that they need to detox the cell, is what they're claiming, for a detox of the system. I ran into somebody who had a similar experience to me, and they created a product that detoxes the cell.
Well,
and I'm wondering what that means.
The term detox means ridding it of toxins.
Okay.
Now, what those toxins are is very can vary. In the case of what we're talking about, is we've got intracellular pathogens,
Okay.
mycoplasms and such, that live inside the cells, and they shield themselves from the body's mechanisms of immune mechanisms. Now, the oxidative therapies are really small charged molecules, and they just get right in there. They pass right through the cells. Now, once they pass through and they destroy the pathogen, the cells now are free to rid themselves of it. So they detoxify themselves, they throw it out. So that's where the term comes from.
And so that means, like, for example, even if you have a cancer or anything running through your blood, this in essence will go on contact, kill it? Is that a fair?
Can. No claims are made for cancer.
Okay, my apologies.
No claims. It can, some cases.
I should say infections then.
Well, infections I can speak on.
Okay.
Cancers, if you're saying is cancer an infection, the answer is I'm not answering that question. I'm not going there. It's above my pay grade, so to speak.
Okay. But in essence, somebody, like, even for example, today I had a flu-like symptom. And so theoretically, this can be used on anybody who is not feeling well, who, like, for example, I'm in a position where I can't take that many more antibiotics because my system's becoming immune to them. So you gave me the oxidative therapies, and I wasn't functioning before you gave me the therapy. And then afterwards, I actually came back to life. Can you just describe that a little bit?
Well, if you have in the process of a viral infection, a flu-like reaction, the oxidative therapies, all three of them, go into the bloodstream very quickly and clear it. So the symptoms disappear immediately. The main difference between these three therapies, beside the fact that one's a liquid, one's a gas, and one's just a rays, so there are different mechanisms of delivery. UV is a rays, also ozone is a gas, and peroxide is a liquid, so they're given different ways. But they also have different durations of action. And this is really why we prefer UV the best over the other two. Ozone and peroxide are very unstable solutions and molecules. They last minutes to perhaps a half hour. If you administer any of these to a patient, peroxide or ozone, in any way, the action is gone in 10-15 minutes. Now, UV is a little different. Once we charge up, once we expose the UV light, to expose the red blood cell to the UV light, that UV cell, that blood cell rather, emits, you can detect UV coming off that blood cell for up to a month. So you're getting some form of UV in your circulation for the entire month. Now, towards the end of the month, you're really not seeing very much, but you will see a significant clinical effect for a good 2-3 days. You won't see that with peroxide or ozone, and that's the reason why we're able to give UV treatment twice a week, and we don't have to give any more, because by the time one treatment is ending, the next treatment is starting. You can't do that with peroxide or ozone. You have to give it daily or very close to each other.
Why is this not known about? Why is this a treatment that is not taken in by hospitals, doctors across the world? I mean, why isn't this just a treatment that should have been just like antibiotics? This should have been.
It is used in some cases regularly, in some countries rather, I beg your pardon, they'll use it. But
It's done in other countries?
But yeah, it's done all over the world. But as everything else, if something isn't used in the United States, it never catches fire around the world. Everything has to start and be used in America. If it's not used in the States, the foreign doctors shy away from it. They have it, but they shy away from it. Not only that, since it's never really been approved for sale or use in the United States, it is used by doctors, but is not approved for use. And because of that, different variations and different protocols are used. There's no standard protocol. Some doctors give too little, some give too much, some don't use it in the right mechanism. You have knockoff equipment that isn't working. So all in all, nobody has done any studies recently. There are old studies, but there are no recent studies. If there were, then somebody would pay for those studies, but it would be very expensive. You need to fund the university, go through an IRB. There was a company that had done this, and the company got it right all the way up to the end, and then the company ran out of money and went bankrupt. So that's a shame, but nevertheless, it had become FDA approved, as it should have been. Then the doctors would want to do it because they could be paid for it, and they would follow the protocol and buy the equipment and do it. But since the doctors can't get paid for it, what they'll do is they'll just find something else. And unfortunately, there is nothing else that works like this.
Yeah, I was going to say to you, again, if we're talking too long, stop me at any time. I was going to say that one thing that I found is that I had to live with antibiotics, and there was a lot of repercussions to the antibiotics in my intestinal tract.
That's the problem. Years ago, when I started doing these oxidative therapy, I had a surgeon look up from his operating table and say, "Why do I need this? I have antibiotics for everything." Well, if you think that today, you're really crazy. You don't have antibiotics for everything. We have antibiotic-resistant bugs. We have toxic patients. We don't have antibiotics. We're running out of it. We need to supplement our antibiotics with oxidative therapy. What I've recognized is, and again, I wish we had a study to prove this, that if you take a patient who requires an antiviral or an antibiotic, you will get in 3 or 4 days where you would get in 10 days if you put the two together. So in other words, the oxidative therapies, especially UV, are synergistic with the antivirals or antibiotics. And this is clearly demonstrated in my patient experience.
Is there anything that you feel at this point? It doesn't mean we're not going to talk again and do this again, because I was going to say to you, as I progress, I think we're going to keep checking and learning new things. Is there anything that you'd like to add to this particular video?
There's always new stuff coming out, always new indications, because my approach to a patient disease is it's an infection until proven otherwise. So therefore, if somebody comes in with a bizarre set of symptoms, I challenge them, because these oxidative therapies, especially UV, is so safe. Why not give it to somebody and see what happens? So I do that. I use it on patients, even though I'm unsure of the diagnosis. And if it turns around, then I know I'm on the right track. And I would say 90 to 95% of the people have a good reaction to oxidative therapy, particularly UV.